Good evening. My topic is efficacy of near-infrared spectroscopy to predict perioperative complications in patients presenting for surgical excision of cerebral arteriovenous malformation. Cerebral AVMs present a low resistance circulation, which renders the perineal tissues susceptible to ischemia. But post-excision, there is an increased flow to the surrounding perineal tissues, resulting in hyperemic complications. Also, therapeutic-induced hypotension and cerebral edema post-op can result in ischemic complications as well. Hence, the crux of perioperative management is to achieve a balance between optimal cerebral oxygenation and prevention of cerebral hyperemia at the same time. NIRS helps to detect cerebral ischemia or hyperemia by measuring the regional cerebral oxygen saturation. While RSO2 cutoff values of 12% have been described for procedures like carotid endarterectomy, there is paucity of literature on the use of NIRS in AVM surgeries, hence the relevance of our study. Our hypothesis was that the use of NIRS helps to detect changes in cerebral oxygenation and helps to predict perioperative complications in patients for surgical excision of AVM. Primary objective was to study the correlation between periprocedural changes in RSO2 and perioperative neurological complications. Secondary objective was to determine an NIRS threshold value to indicate cerebral ischemia or hyperemia in AVM patients. Our methodology, this was a prospective observational study where 20 patients were initially screened. After applying the inclusion criteria and exclusion criteria, 6 were excluded and 14 were included and finally analyzed. All standard ASA monitors were applied and NIRS sensors were placed bilaterally. N1 was the baseline NIRS before induction. Anesthesia induction and initial maintenance was standardized for all patients. NIRS recordings were taken at various time points such as N2, that is 10 minutes after induction, N3 after arterial ligation, and N4 after venous ligation, N5 after resection of the AVM, N6 was the first value post-op in the ICU, N7 to 17 was hourly in the ICU, and NC was a recording at the time of complication. Blood pressure was maintained at baseline throughout surgery. Post-excision blood pressure maintained at baseline or 20% of baseline using SNP infusion or according to the NIRS recordings. A significant drift was defined as a drift of more than 12% RSO2. If such a significant drift was noted, the following interventions would be performed. That is, inform the surgeon or the intensivist, inspect the operative site, optimize anesthesia, optimize FiO2, hemoglobin, and blood pressure, and a tight blood pressure control with SNP or an urgent CT would be ordered. Our results were as follows. 35.7% of the patients were in the age group of 16 to 20 years. 78.6% of the patients were males. 50% of the AVMs were SM grade 2, 28.5 was SM grade 1, and 21.4 was SM grade 3. Most of the AVMs were located in the parietal location, followed by the frontal, followed by frontotemporal and insular and temporal. One patient had hypertension, another diabetes, both were well controlled. We observed that in group B, that is the group where the patients developed complications, there was a significant drift in the RSO2 values post-excision. As you can see, at time point N5, that is at this point, there was a significant drift in the RSO2 value. At this point, we intervened to control the blood pressure more tightly so that to avoid hyperemia. Following that, the RSO2 values decreased. However, at time point NC, that is at this time point when the complication occurred, we noticed there was a significant negative drift in the RSO2 value. Hence, we optimized our blood pressure management so as to avoid excessive hypotension. And after that, RSO2 values improved. We observed that 21.4% of the patients had a significant drift in RSO2 of more than 12%. Among them, there was a 100% incidence of postoperative complications. While 78.4% of the patients had an RSO2 drift of less than 12%, 18% of them had postoperative complications. This signifies that those who had a significant drift of more than 12 had a 100% incidence of post-op complication. Coming to post-op complications per se, highest incidence was noted for generalized seizures, followed by delayed extubation and re-intubation, and one patient each had EDH, focal seizures, cerebral edema post-op, and venous infarct. We observed that 40% of the patients who developed complications had SM grade 2 and 60% who had complications had SM grade 3. In our study, the incidence of hyperemia was 7% as compared to 8 to 21% reported by Chu et al. This low incidence in our study could be attributed to the tight blood pressure control, which guided by NIRS monitoring aided us in identifying the critical BP target in each patient so that we were able to strike a balance between optimizing the cerebral oxygenation and preventing hyperemia at the same time. Also, a significant drift of more than 12% in RSO2 value in our patients want our clinicians to intervene promptly and control the blood pressure more effectively and appropriately. The incidence of seizures in our study population was 28.5%, which was comparable to the findings by Englot et al., who reported an incidence of 12 to 57% after AVM resection. Higher incidence of seizures have also been reported, wherein there was incomplete AVM obliteration and AVMs with deep perforators. In our study, of the 5 patients who had seizures, 2 had residual AVMs post-op and 3 had SM grade 3 with deep perforators. Our limitations was this is a single center study. Other modalities of cerebral oxygenation monitoring were not used and posterior circulation AVMs were excluded. Hence, I would like to conclude by saying non-invasive monitors like NIRS can help to detect changes in regional cerebral oxygenation. A post-operative drift of RSO2 of more than 12% in our study was strongly associated with post-operative complications. Hence, a tight control of blood pressure with a threshold RSO2 drift of less than 12% would help to reduce the incidence of perioperative complications and lead to better outcomes in patients. Thank you. These are my references.